I'd now like to introduce our first presenter, Laura Feldman, who has a long career with DMH as an area manager, and she is the current director of risk management.
Hello. Yes, so let me pull my screen up. All good? Okay.
Yeah.
So I'll just introduce myself. So I'm the risk manager at one of the sites in DMH, at the Erich Lindemann site, and I'm part of the Metro Boston area. I've been with the department since 2004. And so I'm just gonna do a brief kind of overview of DMH, adult DMH application process and services in Mass. And I know I'm just gonna I might be going through these slides pretty quickly because I know I only have so much time and there's other people to present. But if you guys want a copy of the slides, I'm happy to, Cassie, if you want to send them out to people, that's fine. So just to kind of a review of the objectives, so we're just gonna summarize how adult DMH is broken up across the state, emergency services overview. I'm going to summarize the determination process and eligibility criteria, and how we can assess a person's immediate or emerging needs in relation to eligibility criteria, and just an overview of DMH services. So just so you all know, and I don't know how familiar you are with DMH, but we have 5 areas across the Commonwealth. There's Metro Boston, Northeast, Southeast, Central Mass, and Western Mass, and each area is broken up into sites across the state. And there are 27 DMH sites in the Commonwealth. And the best way I can describe how to figure that out is I'm going to give you a link at the end, and it's our Mass DMH link, and you can go onto the website. There's a way you can search the town that you're looking for where the person is living, and then you can it'll show you what site they're connected to. And you know, obviously you might be working with people that you don't know if they have DMH services. And so what I would just say is to give the site a call where the person is living, what site they're connected to. And just see if you can get a release from the person you're working with, and just ask the DMH site if they have services with the department. And if they do, then there's your collaboration, your connection to DMH. If they don't, I'm just going to briefly walk you through the application process.
No barking.
Is that just okay? That's not a question, is it? No, okay. But before I do, I'm just going to talk briefly about emergency services. I don't know how much folks know, but there are psychiatric emergency services programs that cover every town in the Commonwealth. And they can help in kind of an emergency situation if you guys are going out to see an elder who you're really concerned with, or maybe they're not quite like a 911 call, but there is some concerning behavioral health needs. I put the number here. It's a statewide number that you can call, and they'll connect you to the psychiatric emergency services team that covers the person's area. And so they can kind of provide you with some crisis management support, interventions, resources, to help the person in the moment. So that's just one resource that anyone can access without DMH support. And so the adult application, I don't know how many of you guys would be filling this out, but I will just briefly go over the process. The application is online. You can fill it out online, or you can print it out and mail it in. And the link that I give you will also show you how to get to the application. The application does have to be filled out by the person that's going to be receiving the services, unless they have a guardian. And in that case, then the guardian would sign the application, and they'd have to provide the guardianship paperwork. What's really important in the application process is to fill out the releases of information. So we're only as good as the records we get from some of these hospitals, outpatient clinics, to determine whether or not someone meets the eligibility. Most of the time, we don't see people on the preliminary eligibility. So we make a decision really based on records and talking to people who work with the applicant. If there is a history of substance abuse on the application, you have to initial, because that takes a special authorization to get records with substance abuse in them. And I would just encourage if you're putting in an application, just to submit as much clinical information as you know. Once the application is received, then we have a certain period of time in which we have to reach out. And then from the date of receiving the information, we have 90 days if the person is found, to determine whether or not the person is found eligible or not eligible. These are the diagnoses we find that that folks will meet on for criteria for DMH services. So as you can see, they're most of the significant access 1 diagnoses in the DSM. Non-qualifying diagnoses are this list. There's a lot of them on there. But I think the main thing that I would just say is that the primary diagnosis, has to be mental health. So if we're finding that substance abuse is the result of symptoms or traumatic brain injury or primary dementia, then they would be screened out. So again, this goes over that developmental disability. We wouldn't find eligible as the primary cause for the functional impairment, learning disorder, autism spectrum, and personality disorder other than borderline. So once the person is approved, we assess that person in person, and they can invite anyone they want to that preliminary interview. We'll talk to them and find out what their needs are and what they're looking for from DMH services. And usually what we'll have to, once we get the application, we have 30 days to make that appointment with the applicant. And most of the times, if we see the person and they're wanting DMH services, we will provide DMH services. So just to overview of DMH services, we have a number of different services that we provide. We have case management, and for case management, it's pretty kind of low barrier in terms of what we are required to do with the person, and sometimes that actually works well for people that are new to the system, because we only have to meet a person once a month if it's case management. So if they are kind of hesitant about getting DMH services, it's a good service to start with. But if is a person that needs more support in the community, then we usually refer them to what's called ACCS, which is Adult Community Clinical Services. And those are kind of a wraparound programming with a team of people that meet with the applicants or the clients on a weekly basis, or more than that if the need is there. And they don't substitute for outpatient, so they would still have to be getting outpatient mental health and psychiatry, but this is just additional outreach to the person in the community. Sometimes what we do is we support people with VNA support, making sure they're getting their medication, helping with housing, connecting them with benefits, and then, you know, how vocational training, health and wellness referrals. We also, our ACCS teams also oversee all of our group homes in the state. There are certain areas of the state where there's still state-run group homes, but for the most part, our vendors are the ones, and our vendors are who work, who are the ACCS team. So we fund vendors to provide the ACCS services. And then there's also another service that we provide is our clubhouses. And so there are 33 clubhouses in the state. And so again, whatever town you live in, you can go to the clubhouse nearby, or there's a lot of clubhouses that take folks from other towns. And it's a really, those clubhouses are really nice for folks because they can be drop-in, and it's a great place to socialize, great place to connect around vocational goals. The clubhouse in our area is Center Club, and they provide a lot of like hands-on training for people in the kitchen, in the computer training and writing. So it serves as kind of a place also if someone wants to build a resume, and they also really help with, you know, just ongoing support and day structure for people. We also have recovery learning centers, and those are also across the state. Those are peer-run programs that we fund to help our folks also connect with other peers. And there's, you know, they also provide a lot of different types of support. They'll have, the ones in our area will have groups. They have arts groups, they have symptom group, they have, you know, socialization. So it's really dependent on what they want to work on in their own center.
And Laura, there's a couple questions in the chat. Becca asked, is hoarding disorder eligible as a primary diagnosis? It has its own code and lots of people need help. And I absolutely agree with that.
Yes, I have to go back. It's been a little while, but let me go back because I think it is. That was one of those areas that a couple years ago it wasn't, but I think that has changed.
Oh, under obsessive compulsive and related, perhaps?
Yeah, I think it's either, yeah, I think it might be under that. I'm gonna have to get back to you on that because that was one diagnosis that I wanted to check on as something that might have changed over the last years. But I can, when someone else is going, I can let you know. I can answer that.
And there's another question. If a DMH application is denied, is the older adult referred to an EMOD or MHOT? I know not area has one of those, but I guess the question still stands, you know, are they referred elsewhere?
So there's not much in terms of what our obligation is with the application. We don't really have an obligation to refer people out. What we usually do is when someone gets denied clinically, we let them know that they're denied. In the denial letter, it will make reference to organizations or agencies that we think they would be better served at. So I know for some of our folks that have elder services, we have referred them back and suggested elder services as one of the resources that they can access. But our clinical department, at least in Metro Boston, gets 100 applications a month. And of those 100 applications, maybe 2/3 of them are approved and 1/3 is not. So they just don't have the power to work with every single, to refer applications who are denied.
That's really the second part of that question is if the application's accepted, is MHOT or EMOT included in service planning? Ideally, yes. I think part of why we have these webinars and kind of cross networking and training opportunities is so people are aware of each other and are working collaboratively on these complex situations.
Yeah, and I think the other thing is we've gotten a lot of applications from MHOTs too. So we can collaborate together to try to get them all their needs met in the community. So it has been really, really great to collaborate because oftentimes if MHOTs are already involved, then they have already built that relationship with people and we're just new people coming in. So it's really important that we kind of connect together on what the person needs so that we don't scare them away. So, I mean, that would be the other thing I would just add to that. So like, if you know an application is going in and you're part of an MHOT, and so the application, you might not put the application in, but someone else does, I would just suggest that you put your name on the application or the person putting it in so that there's a way to contact you when we're reaching out. So yeah, if we're finding that they don't have a need for services, we'll say that, we'll write that in a letter. For folks that are denied, there's a process in appealing that. And so there's a number of steps that on a clinical, if they're denied clinically, they can appeal it. And usually the appeal either includes additional information, additional records that they want to add, or they might ask for an informal appeal and a face-to-face interview. And in that case, office and meet with the clinical staff. And then from there, they'll determine whether or not the denial gets overturned. There's another level after that, and then another level after that. So there's many opportunities for someone to try to appeal a denial if that happens. And so the other thing I would just say is, one of the reasons why I would say if you have an inkling that someone might have had DMH services, to get a release and call the site, because oftentimes if someone had DMH services in the past, it'll be a much easier process to get them reconnected. So a person's eligibility lasts a year from the last time that they were connected to us. So, and even if it's been over a year, as long as you provide a little bit more, some more records, or maybe you don't have to be as thorough with the application. So like once they're approved, it should be easier to get them reconnected. So yeah, this is just talking about the appeals process, importance of a face-to-face interview, presenting any new documentation, and just the application cheat sheet on this. And then this is the website that I was referring to. So I will, let me look into the hoarding thing, because we do a lot of work with people, and that's often a lot of what happens and how we get connected to initially to people who are really in an emergency situation, or people that are starting the process, or they're starting the process of getting evicted for pretty significant issues. And so that the only thing I would just add to this also is that if you guys are applying for for DMH services on people, and there's an immediate need for us to get involved, there's a way for us to have a critical needs case manager during the application process. And that can be determined, that'll be determined by the site and the area, whether or not it makes sense for us to get involved during the process.
Another question from the chat box. What is the wait time between acceptance and services starting?
So if the person, when the person gets accepted, from the moment of the application that the application gets in, we have 90 days to either to approve DMH them clinically and approve them for DMH services. So that's 90 days in total, but we really try to do it sooner than that. Especially if there's a really urgent need, we'll try to push it along. And so I think whatever your advocacy can be in the process is really helpful. But you know, a lot of times, and it depends on the site, but for example, at the Lindemann, ACCS is harder to get. We have only so many contracted spots. And so it's the same, and for the most part, I would say it's probably the same across the state. We're more likely to be able to give case management quickly than we are to give ACCS quickly. And so depending on the need, we might just assign a case manager until ACCS services can get connected. So, but that's our time frame, is that within 90 days, we have to approve, deny, make a decision, and then figure out services for the person.
Thanks so much, Laura. Any other questions for her before we move on to our next presenter?
Is there an age
limit? Yeah.
Miss Judy Fonch. So age limit, no. So for adult services, they start at 18 and they go up to whenever the person wants our services. So they can go as high. I mean, really the whole thing is, what is the clinical presentation when they come in? So is the primary presentation still mental illness as the primary cause of the functional impairment, and with those diagnoses that I listed? So that has to be the primary cause of the functional impairment. And if that's the case and the person wants our services, then we should be able to provide that.
And I've been really impressed with DMH's response with some really complex cases in which somebody was at very high risk of eviction. And I think one thing DMH does really well is kind of have a crisis, almost like case conference, where it kind of bring in a lot of people from DMH as well as kind of on the ground to kind of really put our heads together and really think about what are the best resources we can offer.
Yeah, I mean, I think that's the key. Is like, you know, if you guys can connect with the sites, and even if they're not DMH clients, but you're trying to figure out how to maneuver this situation, it's good to have someone at DMH that you can connect with, and just to try to figure out, like, would it be worth applying for this person? Would it not be? If not, what are the resources out there that you guys might not know what's out there? So we have a pretty good handle on the resources in the community. So really depending on what site you work with, I think it's really good to have some sort of connection with a DMH person there.
Our next question from Kathy, at what point is a DMH client introduced to senior services, or are they?
As soon as we can. And I think it really, you know, I think, so on the flip side, I think it's really helpful for us to know more about when we should do it. I think, you know, I would love to have more trainings for our site, if not for our area, just in terms of like, when would be appropriate for us to kind of start thinking about that.
And I should
And
add that that's our next training will be early next year, training DMH providers on the aging service system. And if you'd like to be a part of that, lend your expertise or have any kind of thoughts about what's important to communicate, you can feel free and reach me. I'll put my email in the chat.
yeah, I mean, because a lot of times we don't know, you know, when we file, let's say, you know, as a mandated reporter, like we file, you know, a concerning, like an elder report, for example. We don't always know what happens with that. And so it would be helpful for us to know when to get elder services involved. And for us, it's usually when someone is having a more difficult time getting out of the house and or needs more socialization or more in-home supports that we can't provide. So, but you know, there may be a time where we can look at it even before that happens. And so it would be helpful to have more understanding of when we should be reaching out.
Awesome. Thanks so much, Laura. And with that, we can move on to our next presenter, Brenda Vizina from the Kiva Center. And I believe she's going to be joined by her colleague, Vesper Moore.
Thank you so much for tolerating my dog barking there. I think that's what we get by working at home in this new world. Thank you for having me. Thank you, Laura. I learned a lot from that presentation, so I really appreciate that. Vesper, you have the slides, I believe, to show. So my name is Brenda Vizina, and I am the CEO and Executive Director of the Kiva Centers. My pronouns are she, her, and hers also Elle. And you can find us, you know, at kivacenters.org. We serve across the state of Massachusetts, but primarily funded by the Department of Mental Health. As Laura said, recovery learning communities are across the state, but we also have multi functions in our organization. So our organization has one recovery learning community that's split into a few parts, one that's a Spanish speaking only and one that's in Worcester, and pretty much a traveling one that's a mobile RLC. So that's kind of a little overview of our community. And then we have all different parts of our business. So Vesper is the COO of our community, of our organization. It's a peer-led, Indigenous, female-led organization that's multicultural, multilingual. And so we'd like to get to know you a little better. And so we're pretty excited about being here. And thank you, Cassie, for inviting us. One of the things that we really think about when we think about older adult peer support is that our values about peer support go across all ages. So, you know, age 15 is really where we get started. And the oldest person in our community happens to be my mother, who just passed in June. But she was running the elder support groups and she had 10, 12 people a week. She passed at age 90. So, and she'd been coming to Kiva since its opening 15 years ago. And so she really enjoyed it. And what it gave her was a social outlet, it gave her a quality of life, it gave her friends of all ages. It gave her kind of a Mobius strip of, you know, integrated wisdom shared by a 15-year-old with a 90-year-old. And then, you know, COVID hit, and peer support is really about connection, relationships, resources, listening, being with a person, not judging. It's a safe place where you can say anything that doesn't get written, that doesn't get repeated. And that, you know, you can bounce ideas off another person who may have a similar situation or may have been in a similar situation. So you can kind of get that, which isn't like therapy, it's peer support. So it's, you know, it's quite a different animal, I'll say. So in older adult peer support, some of the innovations that we found the need for. I can't see the slides yet. Are you going to show those? Primarily what we asked the older adult community what they wanted us to talk about. So we brought you those slides. And what they wanted to talk about was our, what we call older adult peer support innovations. Now, we're the only organization in the state of Massachusetts that does certify peer specialists. So, but there is the micro credential of older adult peer, it's called COPES, Certification of Older Adult Peer Support, that Rob Walker runs. Some of you might know about that. And so some of that's in those, some of the things that are in those innovations could be, you know, introducing older adults to some technology by the younger adults, or people that maybe not even younger, but might know it or understand it a little more, maybe perhaps gain access to the Jitterbug. If some of you know about that Jitterbug phone, it's changing its name now, but we're in conversation with them because there's a medical button on there where you could reach a nurse or a doctor if you had an emergency, but there's nowhere to reach someone just to have a chat. And we all know that loneliness is a public health crisis. So peer support could really help with that if we were able to be part of, you know, some of the innovation in technology and these telephones that older adults are getting. So that's a place of innovation for us. And so it's really about fostering the connection, sharing the lived experience, and really valuing what the older person is bringing to the community. Particularly during COVID, we learned about making bread. We learned about sustainable, you know, kinds of ways to make our houses more sustainable by people who have been through the Depression, by people who have been through other hard, difficult times. And it really calmed our younger adult community, I have to say. We learned how to can things. We learned how to do some of those things that made our resources stretch. And that was really done by all of the older adults. And when I say older adults, I'm saying 45 to, you know, my mother's age, which was 90, not people that are necessarily involved with a physical issue, but really with a mental health condition. But also everybody brings everything with them, right? So there's older adult substance use, there's older adult physical deterioration in some areas that make people feel, you know, less valuable. So we use all of our tools in our toolkit to talk about that, around empowering people to feel more valuable and wrapping the community around people. Go ahead, next slide. And so this is really like impressive to me, because during this COVID-19, and still, you know, we did a whole bunch of accessibility trainings where we bought telephones and we brought them to older adults that didn't have them. You know, we brought the kind that had bigger buttons, larger fonts. We brought printed visuals for people to be able to use and to stay in contact. Not everybody understood Zoom. It was really an isolating time. Even if you lived in congregate housing, or if you lived in senior housing, some people live by themselves. We stayed connected with peer support, in-home peer support. People called us for that, tech support, and learning how to be on Zoom. And we also bought plenty of those, I think they were called the portal, through Facebook. So that was a little easier for some people to navigate. But we also did the grocery shopping, and we took people to get their shots in the beginning. We took over 300 older adults to get their shots, their vaccinations if they wanted them. And now we're at 200 boosters, around 200 boosters. So supporting them in home, supporting them with, you know, whatever they need in terms of that. We're talking about people, you know, in COVID and without, but even people prior COVID and still now, people are working. Some people are older adults like myself, I'm 58, are still working, right? And so AARP says that we are bringing in $7.3 trillion. People from my age group to 72 are bringing in that amount of money. So there's still a large group of people contributing to the economic activity of the United States here. And so we also help people learn how to keep up. So we've gone in their house, if they still had a job that they wanted to do, and help them set up a computer, help them learn how to stay connected in their job so they didn't lose their income. So there's been a lot that we've been able to do with peer support. That's all peer support. That's what peer support is at the heart of it. That's helping people get connected, stay connected, be connected through all of these pieces. Go ahead, Vesper. And so we really do focus a lot on our BIPOC community, Black, Indigenous, people of color. Myself as an Indigenous person, Vesper as well. We really have always focused here on Spanish language communities living in Massachusetts, and primarily people who are living with their grandchildren, raising their grandchildren. They're raising their grandchildren for a multitude of reasons, particularly in the Southbridge area. We have a really large focus there around the opioid epidemic. So the opioid epidemic leads us sometimes to lose people who are parents and young children on leaving them with their grandchildren. So maybe they have passed on from an overdose, or maybe they've been incarcerated, or maybe they haven't come home in a long time. And so grandchildren have had to, raise their grandchildren. And we're seeing that a lot in the Southbridge area. So we've given them a lot of support. We opened a Spanish speaking only center for this purpose. So they come together and they get peer support from each other. They talk about ways that they can, help with the grandchildren. They don't know how to help with the homework. They didn't know how to help with the technology during kids having to go to school online. So we were able to send some folks into their homes and help them get that set up, and set up some study groups for the children, because that was a really difficult time. If you don't know, you don't know, and you're raising a child that needs to know. So getting them computers was something we first had to do. Some people didn't even have that. And so as far as the elders raising grandparents, it is kind of epidemic versus epidemic versus epidemic, right? The opioid epidemic is one of the largest reasons why we're raising our grandchildren. There's other reasons, of course. And then finally, really the pandemic increased emergency room usage. It sure did, for a lot of reasons: loneliness, fear, isolation, and mental health responses to this big unknown scary thing. The world moving so fast, everything feeling so volatile and off balance. And peer support came into that. And so, wait a minute, we went to the government and we said, is there something we can do? Now, we're certainly not saviors. But the one thing we wanted to do is at least put together a pop-up respite, instead of going to the emergency room, where you could come to a place that was safe, and there would be other peers there, where groups could happen, where you could talk about your anxiety and your fear, and perhaps that was a crisis alternative. So we, for a year, did that in the Hilton Homewood Suites on the corner of Shrewsbury Street in Worcester, where we had about 8 or 10 rooms. And we staffed it 24/7, which was great because everybody had their own bathroom. So that was, a nice way to, if you had to quarantine, it was very well run. And then as things slowed down, we were renovating a house in the meanwhile, where we now have 7 guest rooms. And this is actually a guest room that you can see here. We have air cleaners in every room, bed in every room, obviously a bureau, everyone has their own room. There's 3 bathrooms for the whole house. There's a community kitchen. You can see a tour of it on our website. It's quite beautiful, I have to say. Staffed 24/7 with peers, with people who have used the space, or people who are, taking care of the space. It's free of charge, very low barrier to get in. One of the things is one of the barriers to getting in is having a place to return to. We don't want to take people that are unhoused and then have to put them out in the cold. That's a difficult decision to make. And so it's really a crisis alternative if you're feeling like you need to go in a hospital where it might be more unsafe around COVID. So I know this presentation isn't about COVID, but these are the innovative things that we were able to do during COVID. So now we have this Karaya Peer Respite House. Vesper, would you like to say what Karaya means?
Absolutely. So Karaya is a Taino term for the word moon. I myself am Taino, Arawak, Kaskea descent, and the meaning of the word moon is supposed to be representative of enlightenment, rest, and self-reflection and reflection in general. Karaya has been a really good intergenerational example. We've had a lot of young adults and older adults in that space. We've seen people learn from each other through shared wisdom and interdependence, like Brenda's been speaking to. And this respite, after opening January 4th of 2021, has now sustained permanent funding, and we are out of this house. So.
Yeah, it's really vital, I think. Thank you, Vesper. I think peer support is vital to the lives of the people in our community. And I would encourage all of you to think about connecting to an older adult part of a recovery learning community, really, or calling a recovery learning community who's still, doing a lot of Zoom groups. Some aren't open yet, some are. So kind of like clubhouses, although clubhouses are more drop-in. This is a little more intentional around mobiles. We can come to their home and see people, and talk with them and bring some other resources.
Can I ask a question about the respite?
Yes.
A couple questions. One is, how long is the average length of stay there? And another is, I guess this is hard to predict, but what is the general availability? Is there a wait list?
We don't operate on a wait list. The general availability is pretty high. I mean, right now we have 5 people and 2 empty rooms. We don't have really great numbers yet because critical mass, but I think the average length of stay has been 14 days and we've gone as long as 30. And the initial orientation is 5 to 7 days. And then people around 7 days will say, I'm not ready to go home yet. Can you take me over to feed my cat? And somebody will, and then, come back. So we can give people up to 14 or 30 days, and it's worked out beautifully. In terms of a wait list, we don't find it very fair. It's a crisis alternative. So somebody really needs to go to a hospital or find another alternative at the moment that they're being recommended as a guest to us, then we try to help them find something else. Or we offer a mobile service where we'll go right out to their house and see them there until there's a room open. So we have those conversations with the individuals.
That's great to hear. And this is the second one in the state of Massachusetts, correct? There's one in West Mass, and then this is in Central Mass and open primarily to the Central Mass area. Is that correct, or am I wrong about that?
Open for the whole state.
Okay.
So it's not enough for the whole state, but we get people from all over the state. I know Western Mass is smaller, I think 4 beds or something, and they've been great. They've been open for a long time. And we are different in that, we're serving the state and that we were created differently out of a pop-up, out of an emergency.
Thank you.
You're welcome. Next slide. This is really important. What our older adults asked us to bring up is that grief is something that is kind of adverse in this culture where people don't want to talk about it. And some of the things that we're processing as a world right now is grief, everyday anxiety with the way the world is right now, so uncertain. And as we grow older, it's inevitable that other people will grow older and we will lose people. And so we have our sharing and caring and living with loss groups. We talk a lot about grief. It's interesting how many older adults in the grief groups will say how they're, being told at 6 months they should be further along. And it's almost dreadful to me to think that that would be said to anyone. Grief is such an individual thing, and complicated grief and intergenerational grief and all of that, as most of you on this webinar will probably understand. So making sense of our grief and belonging together and having a non-judgmental place to talk about what you really feel without the threat of a hospitalization, without the threat of a phone call being made against you, without the threat of losing your children or your grandchildren if you sound depressed, or if you feel depressed, or if you're hearing voices. We have other groups for that, groups for hearing voices to normalize some of that stuff that, maybe some of the community doesn't find very normal, and that can reduce hospitalization by entering that space with a person and help making sense of these hardships and help them with so what can we do? How can the community wrap itself around you? And how do you want to wrap yourself around the community? Because one of the main things is mutuality. As we get older, we feel less and less worthy of anything. I have to ask Vesper to come on here with me and help share my slides because I don't know how to do it. I have to ask Vesper to make my fonts larger. I'm sure there's many of us that are like that are learning. And so as we evolve in this tumultuous time, I also have a lot to give. So my value, doesn't get reduced because I need help with a font because my eyesight is waning, or technology because I haven't, mastered that yet. So where can I be helpful? And people celebrate the places where I'm very helpful in decision-making and leadership and all those other places that I'm still valuable as a female in the workforce. And so same thing with people that are aging that might start to feel embarrassed about their needs, embarrassed about needing help getting up a stair, or embarrassed about bathroom habits, and embarrassed about increased need for assistance in any place. And so what peer support really does is help kind of not minimize the importance of it, but minimize the embarrassment and really make it about this is life, and what are the things we can do to make it easier? What are the things that we can make aging with dignity easier, for you? People have lost a lot of things. People have lost teeth. They've lost eyesight. They've lost agility, licenses, all kinds of things. So independence is compromised a lot. And so I think peer support really helps with increasing independence. Somebody will pick somebody up, or somebody will help you learn how to run a meeting, and you're still running groups, you're still giving back to the community, you're still valuable. Or you're keeping your job because we're helping in the background, peer supporters are helping you in the background. So, but grief, people have lost their parents a lot this year. We have lost a lot of people in our community this year. And it's becoming a thing where, people are saying, we're not even stopping and talking about it. and the next one happens, and the next one happens. So, you know, we really want to talk about how people are feeling, older adults are feeling about this ever-changing world and losing so many people. So we have created more grief support and online support and in-person support. And I think some of the innovations that older adults have, you know, there's all these tech groups, you know, making all these innovative things, robots, AI, stuff that remind people to do things, watches that tell you it's time to take your medication, all of those kinds of things. What we've learned is people don't want to wear a big honking necklace around their neck. It's embarrassing. And so we've really tried to, you know, help people with the smartwatch and help people get, you know, make it a little more dignified to age gracefully. So in this sense, you know, again, the Mobius strip, there's no beginning, there's no end, and every part of that strip has value. And the people in our community, no matter what age, are all valuable. The focus on the older adult, what their needs are around, you know, the digital peer support that that Rob Walker has brought in has been really helpful. Teaching people to text has been really helpful in communication. FaceTime, we FaceTime a lot, and we go to all of the senior centers and all of the Fallon centers as well, and present on group elder, older adult and elder peer support. And so we also help connect people with services. So like, we're a great resource because we help people connect to elder services, attorneys at elder services. We've connected people with that wanted to get a divorce, you know, and then, you know, people say, well, old people don't get divorced. Yes, they do. They still want to get divorced. And so, you know, we help them get the attorney, or we help them keep their house, or a lot of those kinds of things peer support has been able to do. Get them connected with Tri-Valley Elder or VNA if they need that. Write letters to their family members, or any number of those things. Have art classes and yoga. We have chair yoga for older adults. We have Tai Chi for older adults to keep people moving. And, you know, we have all kinds of things. We even brought in these robotic purring animals. You know, we have a cat that moves, you know, for support if somebody wants to take home the cat. It's called Joy for All. I don't know if you're all familiar with that. I think nursing homes and other homes have that. The younger folks didn't like it. They thought it was creepy, but the older folks liked it a lot. So there's a lot, that's an innovation right there though, right? Making a cat that can purr in someone's lap is a support. And so I think, you know, we find it all. We find anything that can be a support to that person, whether in a nursing home or living at home, or unhoused older peer support. We also pay close attention to that. So thank you so much. Is there another slide? I think that was our last slide. So my life isn't over yet. My mother said that right up until her 90th birthday party. And so we have all kinds of things, dancing, yoga, like I said, and, you know, all kinds of trips that we have taken in the past. COVID has put a little damper on that, but even older adults come to karaoke, or, you know, our drumming circle, or our art classes. We have a lot of older adult art, poetry, reciting poetry, and podcasts, and going on our radio show. So no, their life isn't over yet. And how can we make it sweeter and better and improve the quality? That's what peer support is there to do. Thank you.
Thanks so much. And it looks like there's some comments in the chat. Peer support is the best. You're giving me hope for my older years, says Becca. This is a great presentation. Any more questions? And just a side note, Deborah Delman is in the, I saw her as an attendee, and she is actually doing a project with us, kind of looking at how we can increase the availability of peer supporters for older adults. So if you have any feedback for her, we can put her, or input for her, we can put her email address in the chat, because she's open to, you know, everyone's ideas about that.
We're actually having matching systems going on. So there's a place on the website where you can ask, or you can text myself or Vesper to match a peer support person with another person. If you want someone older, everybody doesn't want an older person. So sometimes people want someone younger to talk to. Sometimes somebody, so we don't kind of go, we ask people, what are they looking for? And then we'll match them and do mobile support. So, and we'll work with the social workers. We're not exclusive, like we'll work with people outside of the peer world. We're really, kind of X teams where we, like to be part of the entire stakeholder community, not just ourselves. So we call DMH, we talk with people, as long as we have the person with us, because we, nothing about us without us, right? So we will help them navigate the systems. So thank you.
Thanks so much, Brenda and Vesper.
Appreciate being here. Thank you so much.
Yeah, and our next presenter is Michelle Ward from NAMI, kind of rounding out our overview of some resources in the state, here to talk about NAMI programming.
Hi, everyone. Thanks so much for having me here. I'm going to go ahead and share my screen. Give me just a moment. All right, so hopefully everyone can see this. So I am here from NAMI, Massachusetts. NAMI stands for the National Alliance on Mental Illness, and we are the Massachusetts state chapter. So we work specifically within the state of Massachusetts across the entirety of the state. Our office is based in Woburn, but we work all across the state. And as Cassie said, my name is Michelle Ward-Gilles. I'm the Division Director of Community Education and Outreach at NAMI, Massachusetts. So I work on a lot of our presentation programs and external programming. And today I'm going to talk with you about most of our NAMI programming, specifically talking about programs that would be beneficial and helpful for older adults and really adults of all ages as well. So a little bit about NAMI, Massachusetts. We are a nonprofit organization and we were founded in 1982. We're part of a three-tiered network. So there's NAMI National, which is based just outside of DC, that is the national organization. And then every state in the United States has its own state organization. We are the state organization for Massachusetts. We're our own separate and distinct 501c3 nonprofit, but we do of course collaborate with the national organization. And then similarly, there are 17 local affiliates in the state of Massachusetts that are regionally focused on different areas of the state. And again, they are their own separate and distinct entities, but we do of course work together, collaborate, and we support each other in that work. And overarching, what NAMI Mass aims to do is provide education, support, and advocacy for people and families who are impacted by mental health conditions. So we work with people who themselves are living with mental health conditions or have experienced symptoms of mental health challenges. And we also work with families. And then we also do work that is more external around increasing awareness and understanding in the general public about mental health issues and people who are impacted by mental health issues. And I always like to start out by talking about kind of the overarching thing of why our programs are effective and what we really aim to do. So everything that we do is really coming from personal experience. All of our volunteers, all of our class leaders, support group leaders, presenters, all of our staff, all of us have lived experience of some type related to mental health. So either we ourselves are living with mental health issues like I am, or it is people who are family members, loved ones, caregivers of people living with mental health challenges. So we're always coming at this from that lived experience perspective, that lived experience expertise. And then we also very much recognize there's no single experience related to mental health. No, people with the same diagnosis can have very different experiences. Family members who are supporting someone with similar diagnosis can also have very different experiences. And so any of our support groups, classes, presentations, they're always delivered by at least two leaders, two presenters, so that multiple perspectives are taking place, and we always welcome space for different experiences. And of course, always want to make sure we're providing facts and information. There's a lot of misinformation out there related to mental health. So want to make sure that, in our in our groups, in our classes, that information is correct, and that we're also, folks who are attending our presentations or classes or groups, that they have strategies and resources that they can walk away from with right away, that they can use, they can apply immediately. Kind of overview of the things that we do. We provide support groups and classes for people and families who are impacted by mental health conditions. And I'll talk more in depth about some of that in just a moment. And then we also do mental health awareness education programs really all over the state for many different groups and communities. And we also have some presentation programs that are focused really specifically on certain groups like law enforcement or middle school and high school students, things like that. And then we also run the Compass Helpline, which is a support and referral phone line that helps people navigate the mental health system within the state of Massachusetts. It's a really fantastic resource, and I'll go into more information about that later as well. So first of all, the programs that we have for people who are living with mental health conditions or identify as having mental health symptoms or challenges or experiences of trauma, we have 3 kind of main programs, and all of these are currently available virtually. In 2022, we are expecting to move back to some in-person programming. It's been a bit of a process, as I'm sure all of you have been familiar with in one way or another in your different roles. So we do have peer-to-peer classes, which is an 8-week educational class for people living with mental health issues. And basically it's about like wellness and recovery, about community. And then we also have connection recovery support groups. These groups run, it depends on the group. Some of them run weekly, some run twice a month or once a month. Right now, all of them are happening virtually. And then also something we started during the pandemic is something called NAMI at Home, which is kind of more of a hybrid of a support group or a class. There's often the first half of it is a kind of educational type of thing, learning to do something different, or and then the second part is more of like a support group structure. So that's something that we started doing that's a little bit different. You can look at our website to find current classes, support groups offerings, get links to those things. Our classes, our groups are open to adults of all ages. There's no requirements around any of that. And people of all ages do participate in these classes and groups. And similar to what Brenda and Vespa were saying, there's a lot of benefit in having groups that have people of many different ages who can learn from each other and connect with each other and find different ways of supporting one another. And then we also do a lot of work with families of people who are living with mental health issues. And so we have our family to family class, which is kind of the family version of the peer-to-peer class. It's an 8-week class that really works with families to help them learn how to best support their loved one and also how to support themselves. And that class is currently, those classes are happening virtually, but again, we're planning on transitioning to doing more of those in person in the new year. We also have family support groups, which again happen either on, usually most of them are either monthly or twice a month. And again, you can look at our website to find out more information about the link, how to access those different groups when different classes are starting. Our family to family classes, usually we kind of often go on a semester basis. So a lot of new classes will be coming up in January and February. So definitely be on the lookout for those if there are people, who would be interested in that. And again, very appropriate for people, adults of all ages. For most of our family to family classes and support groups, most of the adults in those classes are caring for their adult child or possibly a grandchild. So that's usually kind of the setup there versus potentially like a young adult caring for a young child. But we do have other classes that we do offer that are more geared to people with young children, but these are more for where the child is an adult or the family member is an adult. We do have a monthly support group that we offer. It's virtual and is geared specifically for older adults who are taking care of a loved one who has a mental health challenge. So that the information for that is here on the screen. It meets on the third Monday. It's technically based out of Jamaica Plain, but it is open to anyone across the state. And it is, again, something that's virtual. So it's definitely accessible for anyone who wants to join. And again, this information is also on our website, so you can find it there as well. And then something that we offer, another program, is the In Our Own Voice presentation. So these are free presentations we offer. They're usually 60 to 75 minutes. They're delivered by 2 adults who are sharing their personal stories of living with mental health conditions. And really the goal of these presentations is really to increase awareness and understanding about mental health issues and really break down stigma and inspire hope for people. And the presentation is kind of split up in such a way that the audience has 3 different opportunities to ask questions and interact and really engage. And the presentations really are most effective when audiences do have questions and want to engage with the presenters and learn more about their experiences, and are really interested in just understanding more about mental health and living with mental health condition and what recovery can look like and pathways to recovery. And we do these types of presentations everywhere, literally everywhere. But we have in recent years started doing more with retirement communities and other communities that have more groups of older adults. But we also do a fair amount with community groups, parent family groups, a lot within workplaces, colleges and universities, hospitals. So we go to lots of different places. The presentations are entirely free, and they're a really great opportunity to start conversations around mental health, a really great way for people who may be struggling but haven't found the courage yet to tell someone or ask for help. It's a way of kind of breaking the ice around some of that as well. So they're definitely very effective in retirement communities or other community groups. And similarly, I wanted to bring up that, one other thing that we do, we have volunteers for all of our different programs. Most of the volunteers who run our different programs kind of come up through the programs. They take a class and then maybe they start teaching. In Our Own Voice is a little bit different. We love to have people come and who are interested in telling their own personal stories, looking for people of all ages who are interested in sharing their journey with mental health. We do have trainings coming up in January and February, and someone who's interested can apply on our website, and then goes through an interview process and everything. But these becoming an In Our Own Voice speaker is a really great opportunity to learn more about public speaking, to share your story, to connect with other people who are also living with mental health challenges, to get a chance to talk to lots of different groups of people across the state, and share your hard-won knowledge and wisdom. And we do pay our presenters a small stipend for each presentation. And for presentations that happen in person, we also do reimburse mileage and travel expenses, if they're taking a train or anything like that. Currently, we're doing a mix of virtual and in-person presentations. So either is an option. And I'm the person to contact actually about anything related to In Our Own Voice or any of the outside speaking programs. And then the last program I wanted to talk about is the Compass Helpline, which I mentioned earlier on. This is our resource and referral phone line. And really what the goal of this is to really help people navigate the mental health system in Massachusetts and to help people kind of find their next best step. How to problem solve in difficult situations. The helpline runs Monday through Friday, 9 a.m. to 5 p.m. So those are kind of the business hours. It is not a crisis line. It's not a warm line. It's a resource line. So the phone numbers are here on the screen, as well as the email address. So if someone is interested in contacting Compass, they can call just one of those numbers, shoot over an email, or there's also a way on our website to actually schedule a time for someone from Compass to call you. That can be especially very helpful if you don't have consistent access to a phone, or only want to speak at a certain time when, other people aren't around, or, things like that. So the Compass Helpline, really great resource, can help connect to NAMI programs, but also mostly is helping connect to other resources throughout the state. We refer a lot actually to everyone who's already spoken today. Their Compass helpline is, always connecting people to the resources Kiva Centers provides, as well as services from DMH and many other places around the state, around many different types of topics. And that's it for me. I think we have questions, Cassie, it looks like.
Yeah, there's a few questions in the chat. Kathy asked, are there fees for services and programs?
Great question. No, there are no fees for services. Everything that I've talked about today, we provide completely free, no charge to the person seeking support.
And Jennifer asked, do you currently have any in our own voice presenters who are older adults?
We do have in our own voice presenters who are currently older adults. Always love to have more. Always love to build out our speaker pool even more. But yes, we do have presenters who are older adults who can speak to older adult audiences, or also, having adults of different ages speaking to older adult audiences has also been effective in some cases too.
I knew that because we had a fabulous in our own voice presentation, and they, and maybe it was you, I don't know, the facilitator really tried to match, the presentation with older adults to do it. It was really well received, and they're a great thing to host at senior centers. I know a lot of senior centers do them, and yeah, it's a great thing for people to get involved with too. Person served. I think it can be a healing kind of part of the recovery process for someone to become a facilitator or work in that way.
Yes, absolutely. Yes, thank you for that, Cassie. Yeah, absolutely. Our presenters, any presentation, they're always looking for ways to make sure they're customizing their presentation to the group that's in front of them, and making sure that, making as many connections as possible.
And Judy has a question that I think may be directed towards Laura. It was my experience that ACCS clients could not get typical home care services as there was a barrier because they came from the same resources. That changed.
Yes. Yeah, I don't think that's the case. That's not the case anymore. I can tell you that. We used to, and I think one thing that's, it's a duplication of services is PACE. So if it's PACE and case management, or PACE and ACCS, that would be considered a duplication of services. But typical home care services, home health, VNA, PCA, all of those would be able to continue on with ACCS involved.
So thank you to our presenters and our attendees. You will be receiving a follow-up email in a few days with a link to the recording as well as the webinar materials. And my contact information is in the chat as well as our website. But thank you all for coming, and have a great rest of the day.
Thank you so much for having us.